Hi guys, good evening one and all. Hope I'm audible and visible to you. I just need your quick response on the chat box. So this is going to be the continuation of the previous Prolive class, which is done live couple of days back on YouTube. As already said, so we are going to discuss all 2024-25 questions of NEET and INI-CET, which are relevant to the topic of endodontics, subject of endodontics. Okay, right? So before we start proceedings, if you want the PDF of this particular question paper that is being discussed, it will be available in the first comment. Okay, once the live is done, so we are going to upload the question paper. It will be available in the first comment box. You can just click it and download the PDF of the class. Okay, right, that is one. The second important thing is, okay, right, so we as a team MDSConquer, so in the last couple of days worked so hard, and we are providing you some free content on our app to check out the demo version before you are part of MDSConquer, particularly people who are planning for 2027 NEET and 2026 INI-CET. Okay, so before joining, you can check the demo classes, and before joining, we are planning to provide a provision to interact with the main mentors who has a vast experience, okay, in guiding you both for the entrance examination point of view, giving you a plan, ideology, how to start, because if it is an intern, approach is going to be a little different. That to intern from government dental colleges will have a limited time, or the colleges which are having more OP will have a limited time compared to the colleges which are having less OP. So the game plans are going to slightly vary from college to basing upon the OP and the work and commitments you have within the college. And for a repeater, it is different. And for a working repeater, is it different? Or for a mother who I mean, like, who's carrying a baby or who's delivered a baby recently, so approaches are going to be different. So from an entrance examination point of view, you have different categories of students. It's not same for all of you. So I strongly recommend to have a pre-preparation talk before you're planning to restart your preparation, or before you're planning to start your preparation, even if it is an intern. Okay, right? And nowadays you see people are having plan A, plan B. Okay, chalo, they read NEET, but they have a slight dream of moving to abroad uh, to pursue their dentistry. That can be any country where they have to enter through a license exam, or countries like USA and everything. You can do like DDS over there, or if you're planning to do masters in a different country, you can keep that as a plan B. So plan A may be NEET or INI-CET. So integrated mode of reading also, an integrated mode of approach, and the integrated mode of content also we are planning for 2027 batch, because now you have AI available, right? So AI is making things simple. So that is the reason why previously we don't have this integrated approach of guiding students for two different plans or two different goals. But now as a plan A, plan B, okay, with the help of AI integration and everything, we are executing that. We are combiningly providing you an idea. For all of these things, I strongly recommend you to have a pre-preparation talk with the mentors who has a vast experience overall, national as well as international license exams, or any sort of exam. Like NEET and INI-CET is one pattern of exam to enter into MDS. But apart from this, you have many sorts of examinations in our country too, whenever you want to enter into government jobs. So UPPSC notification was recently out. Okay, so for that you have a different mode of approach for the examination, and followed by you have different sorts of examination. Apart from different state is going to have a different sort of examinations for their government jobs, along with international license exams. Few international license exams, license exams are basically going to have different parts, and few of those parts can be taken in India, and few of them can be taken from your home also. Like for example, you see ADC, Australian Dental Council, part 1, part 2. Part 2 you have to give in Australia, whereas part 1 you can give in India. Hyderabad, Delhi and Bangalore centers are there. So you can plan and you can give here itself. You don't need to move to the country to give that exam. You can plan here and give the examinations. Similarly, like ORE and all these examinations, you have a platforms where few parts you can give here and few parts you can give over there, and few examinations like LDS for UK and everything. You can straightforward give the examination within your home also by arranging these cameras and everything. Okay, so you should know everything, whatever the opportunities are there, whatever the possibilities are there. You need to explore them, and my recommendation is, yeah, you take a chance. So dentistry is something like very vast, and now globally everything is growing, right? So now we are always talking about globally, everything like globally we are talking about, and India is developing well in all the aspects, and yeah, it's a good privilege. So learn about these things and plan about these things. Okay, so without wasting any time, I said like we are providing the free content, some sort of free content, accessing some MCQs, accessing some question papers, accessing some videos, quick revision videos and everything, free for all the users, just to encourage the interface, just to provide you that phase of interface where you're going to learn the concepts and everything. And further, we are planning some clinical integrated live sessions also, where we are going to give some clinical demonstration of the advanced dentistry that most of us are not having access to, encourage you or to increase your bond with dentistry. And of course, I'll try to integrate the concepts also by which you can answer few questions clinically. Okay. So the methodology is, I hope like most of you are aware of MDSConquer website. So that is MDSConquer www.mdsexamination.com. So this is a website where you have to log in. You can use the QR code to log in, or you can download the apps by using these QR codes. Again, we'll be providing you them in the description part of this particular video. You can click the links and you can download. Okay, or if you have any doubts, you can contact these two numbers to book your slot to talk with the mentor or plan accordingly. So it's very easy. Now the free user is very easily accessible. So get into the website. So, and in the different types of courses, you have a free user available. Okay, so click on that. So click on the free user and you can directly go for the payment. Okay, so there is automatical payment will be done. So it's a ₹0 payment. So once you're done with payment, okay, then the basic details of your name and everything, email address and everything, contact number and everything will be given. And once you register, you can get access to all the free content and number of videos. We are providing you the access. Okay, right? So then you can log in with your password and password and email address, whatever you have created. So you can participate in few examinations. We are planning to provide you some PYQs. We are planning to provide you some videos, some examinations and everything. So basically I told you, right? So increase the user interface both for the app as well as from the website. So this is a basic intro and we are jumping into the class. That is extension of the last week class. Okay, right? So last week we have discussed few important concepts. Now I'm extending it. If you're not done with the last week class, you can go into the YouTube and you will find in the live session, you'll find the link of the previous Endo Prolive class. Okay. Now, my main motto is I'll try to cover the most important area. Trust me on this particular concept. In the last NEET 2025 examination, there were like 3 to 4 questions. The questions also I'm going to discuss in the next couple of minutes. So case-based questions on endo are very, very common. So whenever you have a case-based question on endo or pediatric endodontics, pedo combined with endo. So whenever you have a case, like for example, a boy of this particular age of 80 years approaches the department with a chief complaint of discolored anterior teeth with a history of trauma 2 years back, and upon radiographic examinations, the apex is seen like an open apex. Okay, right? And what is the mode of treatment to be done for this particular individual? Can be a frequently asked question. This mode of questions are very, very frequent asked. So whenever you have such questions in the examination hall, my strong recommendation for all of you is to note down few important points about this. Point number 1, okay, whenever you have a case description question with a trauma or something related to endo, okay, or something related to pedo, something related to teeth, and they're asking to find out the treatment plans. It can be direct pulp capping or indirect pulp capping, or it can be apexification, apexogenesis, regenerative endodontics, or a simple root canal therapy, whatever it is. I want you to write down 2 important findings from every question. With these 2 important findings from every question, we can answer almost all the questions in the examination hall. Finding number 1. Finding number 1, vitality. So in the question, they are going to tell you what is the vitality of this particular teeth, or by any sort of information, you need to find out the vitality. The vitality can be vital teeth or non-vital teeth. Okay, 2 categories, vital teeth or non-vital teeth. Again, in this vitality, I will be talking about one important thing. Whatever the heat test, let it be thermal test or a cold test, whatever the EPT you are going to do, whatever the test cavity you are going to do, all these are called as pulp sensibility tests. They are not called as vitality tests. The latest edition of Grossman also it is corrected. Okay, these are sensibility tests. Sensibility test is basically talking about sensation. So this thermal test, EPT, or test cavity, this thermal test can be hot test or cold test, and all these are basically telling you about nerve supply. That is called as sensibility. That is called as sensibility, not vitality. Exclusive vitality tests we have discussed in the last class. Exclusive vitality tests are your pulse oximetry, laser Doppler flowmetry, double wavelength spectrophotometry, and all these are going to come as a vitality test. They are going to tell you about the vitality of the blood supply they're going to talk about. Okay, so even if they're talking about sensibility test results also in the question, you consider them as a vitality, but they are not vital tests. Okay, right? Whenever the info is given, the pulp is responding vital upon thermal stimulation, you can consider it as a vital as of now. The second important thing that they are going to mention in the question is apex. Whether the apex is open or closed. You need to check out whether it's an open apex or closed apex. Okay, how I will get to know vitality? I told you 2 categories: non-vital or vital. Okay, by that going to tell you about the pulp sensibility test, then going to tell you about vital or non-vital. And one category of describing the non-vital is, okay, discoloration. Discoloration is basically due to necrotic pulp. So that can you tell you non-vital. That is the only clinical categorization of telling you non-vital. Non-vital necrotic pulp, they are going to tell you discoloration of a particular teeth after a trauma. You can consider it as a non-vital teeth. The discoloration is basically due to pulpal necrosis. But when I'm talking about apexes, open apex and closed apex, how I will get to know whether it's an open apex or closed apex? One is the question, they can give you a simple description. Apex is open, they can give you. Or in the question, they are going to tell you about the radiographic features. Upon radiographic examination, this maxillary central has an open apex. Okay, one category is radiographic description. Second category is normal description. Normally, they are going to describe you that the pulp, it's an immature apex. Immature apex means open apex. Okay. The third category is trauma. Age of patient during trauma. Age of patient during trauma. Okay, they're going to tell you about the age of the patient during trauma. Okay, for example, normally most of the teeth anterior teeth, because trauma questions are related to anterior teeth. Traumas are very, very rare in the case of posterior teeth. It's an anterior teeth. So whenever they are giving an info about trauma, they're going to tell you about anterior teeth. And most of the anterior teeth, they close around 10 years. So whenever they're talking about 8 years boy trauma, 8 years in the sense open apex, 12 years boy closed apex. But I told you a very, very important point: age of the patient during trauma. It's not about the age of the kid who is coming to your clinic. I can tell you a 10 years boy who has approached to your clinic with a fractured maxillary central incisor at the level of gingiva or something, I'm going to add. I'm going to tell the patient has given a history of trauma 2 years back. Now he came. 2 years back, the trauma was there. Age of the kid is 10 years. Trauma occurs at the age of 8 years. 8 years, if the apex is not being mentioned in the descriptive part or in the radiographic feature, then you have to consider that particular apex as an open apex, because it is trauma. Age of the patient during trauma. It's not the age of the patient who is approaching your clinic. It is age of the patient during trauma. I hope this is very, very clear. So with this findings, you will get to know whether the apex is open or closed. Basing upon that, I'm going to plan my treatments. Right, I hope this is very, very clear. So what are the two important findings I'm going to find out? One important finding is about the vitality, non-vital or vital. Second one is about the apex, whether it is an open apex or a closed apex. Done. With these two informations, you can sort out any sort of question and find out the answer very, very easily in the examination hall. And trust me, this sort of questions in the NEET, I'm not very sure about INI-CET. This sort of questions in the NEET are going to be definitely a minimum of 3 or maximum of 4 to 5 questions will be there, both from endo as well as integrated to pedo. Even this question can be asked relevant to your oral surgery also. Okay, because periapical surgeries, they can integrate and all these things. Okay, now I have two informations. Okay, one is vitality, second one is open apex or closed apex, basing upon which I am going to plan my treatment. Okay, so now in the last class, what we have done, we have discussed. So we have discussed vital therapies, which includes direct pulp capping, indirect pulp capping, pulpotomies also. Okay, pulpotomies also. Exclusively pulpotomies, we are going to top to bottom discuss in pedo, but now I'll try to stick on to my treatment options. One is non-vital treatment options, second one is vital treatment options. Here, vital treatment options, most of them I told you, right, they are part of pedo. So now I will be focusing on non-vital treatment options. So in front of you, you have non-vital teeth. So what is non-vital teeth? Okay, so non-vital teeth. How I'll get to know non-vital teeth? They are going to tell us pulp vitality, or clinically they are going to tell you as a discolored teeth. Okay, so that is a non-vital teeth I have in front of me. The discolored teeth I have in front of me. Now what I'm doing is, I'm doing a traditional endodontics, that is the old generation endodontics, and the latest endodontics is regenerative endodontics I'm going to do. So in traditional endodontics, I have two categories. I told you immature apex means open apex, and the other category is matured apex means closed apex. Similarly, modern endodontics, regenerative endodontics is also going to have open apex and closed apex. Treatment varies. For example, traditional endodontics, open apex, I'm going to do apexification. I told you last class we have discussed apexification. And as of now, we have two important materials which are useful for apexification. One is calcium hydroxide, which is called as multi-step apexification. Second one is MTA, which is a single step apexification. And I always prefer MTA showing best results that we have discussed in the last class. So it can be calcium hydroxide MTA, or it can be calcium hydroxide apexification, or it can be MTA apexification. I told you, NEET 2025 November question is thickness of MTA used in the case of open apex cases. Open apex cases, that is 4 to 5 millimeters. 4 to 5 millimeters. This is what the question that is being given in NEET INI-CET November 2025. What is the problem of this apexification? Problem of this apexification is going to fix apex. It is just split it, apex plus fix. It is fixing the apex, means you are filling the apex. So apexification, the problem of apexification is apexification does not lead to, apexification never, okay, apexification will never lead to increasing in the thickness. Apexification will never lead to increasing in the thickness of the dentinal walls. Okay, dentinal walls, right? So that is the biggest problem of apexification. Okay, right? So I'm going to lead apexification, then jumping into the next part, that is called as your mature apex. Whenever you have a mature apex, I'm going to do regular RCT. Then jumping into the second part, regenerative endodontics, immature apex, I'm there. I'm going to do revascularization. That is a new thing, revascularization. Whenever I have a matured apex, I have procedures like stem cell therapy. I have procedures like pulp implantation. I have procedures like scaffold implantation, gene therapy. But most of these therapies are not in use. They are not in use. Okay. But regenerative endodontics is in practice. So what is going to happen? Regenerative endodontics is basically trying to develop regenerative tissue, like pulp like tissue. Pulp is gone. It is basically where we are going to do this regenerative endodontics, I'm going to do in a non-vital teeth where there is no pulp. What I am trying to do, I am doing something to generate pulp-like tissue. So this pulp-like tissue is going to help in deposition of dentin, closing the apex, that is called as vascularization of the pulpal space with functional tissue capable of developing dentin deposition by which the apex is being closed. Simple two terms I'm going to tell you. One term is called as apexification. You can remember apexification is going to have F in it. F is nothing but filling, fixing. So filling and fixing are basically done by dentist. You, me, everyone are going to do. Next term is apexogenesis. Genesis. Genesis. G for Genesis. Genesis for generation. G for God. Apexogenesis is done by God. God is nothing but pulp. God is nothing. So apexification is done in non-vital teeth by a dentist, whereas apexogenesis is done in a vital teeth by the God, which is nothing but pulp. I hope this is very, very clear. Okay, so don't get confused now. It is very simple. Even if third year and final year students are watching this video, apexification is fixing the apex, which is done by a dentist in a non-vital teeth. Apexogenesis, generation, is done by God. That is nothing but pulp. So you should have a vital teeth. So vital teeth can lead to apexogenesis. Non-vital teeth fixing is called as apexification. So now you guys are very, very clear. So you know what is a non-vital procedure, what is a vital procedure. Apexification is a non-vital procedure. Apexogenesis is a vital procedure. Pulp cappings are vital procedures. Pulpotomies are vital procedures. Pulpectomies, non-vital procedure. RCT, non-vital procedure. Regenerative endodontics, you're trying a non-vital tooth to make it vital tooth. Regeneration, lost, you are trying to generate. So it's a done in a non-vital teeth to make it vital. So it's a you can consider it as a non-vital procedure only. Okay, I hope this is very, very clear. So now I'll be talking a little about regenerative endodontics. I don't know how many of you at a BDS level has studied the regenerative endodontics, which is completely a new concept. Okay, so what case selection? First, I'm talking about the case selection of regenerative endodontics. The case selection is very, very simple. So I told you this is done in a non-vital teeth. I told you this is done in an open apex case. This is already discussed. Open apex case, non-vital teeth, I'm going to do regenerative. Second one, pulpal space does not require post and core and final restoration. Means whenever there is a fracture of a particular teeth that is leading to non-vitality, in the future you don't require a post and core system for that particular teeth, because post and core systems are normally placed in pulp. But in pulp, what I'm doing, I'm trying to generate the pulp. So pulp is being generated. Okay, dentin can be generated, enamel cannot be generated. Okay, right? So post and core teeth, we are not going to do this. And the patient and parent cooperation is required because it's a multi-step. Okay, so a patient has to, along with the parent, has to come for multiple appointments. So their cooperation is required. And patient should not be allergic to the medications or antibiotics which are used to complete this procedure. We'll discuss about what are the antibiotics and materials which are used in this. The patient should not be allergic to any of those materials. So in the first appointment, after case selection, rubber dam application, I'm going to give local anesthesia, apply the rubber dam, open the access cavity, and I'm going to do irrigation with NaOCl. What is the, how much it is? 20 ml of NaOCl as an irrigation solution minimizes the possibility of extrusion into the periapical area. So what I'm going to do, I'm going to use a low concentration of NaOCl. This is what the question already given in the examinations of INICET. What is the low concentration? The low concentration is nothing but 1.5 percentage. 20 ml per canal. One canal I'm going to use 20 ml and the duration is 5 minutes. I'm going to use it. Okay, right? So normally the concentration of NaOCl that is regularly used by us in dentistry is 2.5 to 5.2 percentage. In India, we are going to use 3 percentage bottles basically. But in other countries, they are going to use a little more strengthened bottles. That is 5.2. According to English, if they're asking, your answer should be 6%. Okay, so it is 1.5 percentage, 20 ml per canal for 5 minutes. I'm going to do irrigation, and then I'm going to irrigate with saline, same 20 ml per canal for 5 minutes, and the irrigation needle should be placed, okay, 1 millimeter from the root end so that the apical extrusion is minimized. So then I'm going to dry the canal with the paper points. Okay, then I'm going to place the intracanal medicament. The intracanal medicament can be either calcium hydroxide, or the most commonly used is low concentration triple antibiotic paste. Okay, low concentration triple antibiotic paste I'm going to use. They can ask you the concentration of triple antibiotic paste also. That is a mix of 1:1:1 ratio of ciprofloxacin, metronidazole, and minocycline to a concentration of 0.1 milligram per ml. This is what the question already given in INI-CET recently. Okay, so what is the final concentration of the triple antibiotic paste which is used in regenerative endodontics? Your answer is 0.1 milligram per ml. Okay, now apart from this, what I'm doing, I'm trying to seal that particular area, sealing the pulp chamber with a dentin bonding agent. I'm doing, why I'm doing this, because I am having minocycline, which will cause discoloration. So discoloration chances are there with minocycline. So that is the reason why I'm sealing the chamber with the dentin bonding agent. Followed by, I'm keeping a temporary restoration because I need to follow up the patient for the next appointment, and the thickness of this temporary restoration, preferably cavit, exact value is 3.5 millimeters. This is what the question already given in the NEET exam long back, and a range of 3 to 4 millimeters temporary restorative material is placed, and the patient is recalled for second visit after 1 to 4 weeks. 1 to 4 weeks. So again, the patient came back and I'm starting my procedure. Okay, so what I have done, access to the initial treatment was done. Now previously I have given whatever LA of my choice, but this LA is very, very important because you have questions on this. So what is the preferable local anesthesia that is being used in the case of second visit of regenerative endodontics? That is 3% of mopivacaine without vasoconstrictor. And guys, please do make a note, this is the same local anesthesia of choice. Again, this is an integrated part with oral surgery. Oh yes, you have a question. What is the type of local anesthetic that is being used in thyroid patients, particularly hyperthyroidism patients? What is the local anesthesia that I'm going to use? Same, the answer is same. That is nothing but called as 3% of mopivacaine. Now I'm not going to use vasoconstrictor here. Reason is because now I am over instrumenting to cause bleeding. So you have an open apex, right? So I'm inserting my probe into this open apex case, and I'm inserting and induce the bleeding. So whenever you have a vasoconstrictor, bleeding cannot be induced. So that is the reason why I'm stopping the bleeding. Again, this is a question for you. Now, first visit I have used NaOCl. Second visit, it's very, very important. I have to use 17% of EDTA, 20 ml, and the pH of this EDTA is 7.3. Again, a very frequently asked question. 17% of EDTA, 20 ml, 7.3 pH I'm going to use. Reason why I'm using EDTA, we know that the special feature of EDTA is removal of smear layer, inorganic content, like your dentinal tubules are being blocked. Now when I apply EDTA, this smear layer is going to get removed. Whenever the smear layer is removed, what is going to happen? Nice growth factors will be there in the dentinal tubules, which are going to come inside and mix with this particular blood. Whenever this growth factors in the dentinal tubules are coming and mixing with this particular blood, they can improve the success rate. So that is the reason why in the second visit of regenerative endodontics, I'm going to use EDTA, 17% as 20 ml. So second visit of regenerative endodontics, I'm going to use a local anesthesia that is nothing but called as 3% of mopivacaine without vasoconstrictor. Then I'm going to use irrigation solution that is 17% of EDTA, 7.3 pH, basically helps in removing the smear layer. I hope this is very, very clear. Now cleaning canal and everything were done, LA was given, rubber dam was applied. Now what I'm going to do, I'm going to do over instrumentation. Normally in normal teeth, we never do over instrumentation. Okay, because whenever you do over instrumentation, periapical extrusion chances will be more, and the patient will have lots of discomfort, and you're going to spoil the apical patency. But whenever you're doing regenerative endodontics, you intentionally do over instrumentation and induce the bleeding, create the bleeding. So I'm going to create the bleeding, and now I will stop the bleeding at a level where I can keep 3 to 4 millimeters of the restorative material. Now over that, I'm going to place a resorbable matrix over the blood clot, and then I'm going to fill with either white MTA or calcium hydroxide as a capping material, then I'm going to fill with a restoration of GIC 3 to 4 millimeters. Okay, I'm done. I'm done with my procedure. Now I'm going to follow up the patient repeatedly. Okay, so I call the patient after a couple of days to follow up. So clinically, I'm going to examine the following things. I expect there should be no patient to the patient, no pain to the patient, no swelling to the patient. All these are acute signs. And I expect a positive pulpal response to the patient. Radiographically, I expect a resolution of apical radiolucency, that is your periapical pathology, increasing in the width and length of your roots, assuming that there is a pulp-like tissue that is being formed. Now, I'll show you the graphical representation. This is a periapical area. So you have a you basically have a necrotic pulp, okay, and an open apex case. So what I have done in the second appointment, I stimulated bleeding by over instrumentation. You can see my file is going periapically. So I'm plinging the periapical area because periapical area is filled with lots of stem cells. So all the stem cells are going to come inside along with the blood. So over which I'm going to stop the bleeding at this particular level, over which I'm going to keep an MTA, and over which I'm going to keep GIC. Okay, and I follow up the patient over a period of time. I assume that like pulp like tissue that is being regenerated, and the width and length of your periodontal ligament space has been improved. So you can see in this the end part of the diagram, the E part of the diagram, where you can see there is lots of, just a second. So in the last part, you can see the root apexes are being closed. Okay, the apexes are well closed. Okay, and you can see there is increasing in the thickness of both the length as well as the width of the root. The root is completely closed. An open apex case now has been converted into a closed apex case, and with the help of pulp-like tissue that is regenerated with the process of regenerative endodontics. Guys, I hope this is clear. I just need a thumbs up sign from all of you. Yeah, just hold on. I'll be back within 2 minutes. Sorry guys, there was a network issue. It was resolved. And I hope I'm audible and visible to you. Audible and visible to you. Yeah, right now, yeah. The irrigation solution which I'm going to use in the first visit of regenerative. I just need a thumbs up sign from all of you. Hope I'm audible and visible. The irrigation solution that is used in the first visit of regenerative endodontics is 1.5% of NaOC. And make a note, NaOC is the most commonly used irrigation solution in dentistry in endodontics. And the second visit, I'm going to use 17% of EDTA, 7.3 pH. Okay, right? So, yeah, you guys are right. What is the irrigation solution used in second visit of regenerative endodontics is EDTA 17%, right? So I hope you guys are very, very clear. So jumping into question number 9. Jumping into question number 9. Which of the following shows the correct irrigation solutions, concentrations, correct irrigation solutions, concentrations, and the sequence for the initial treatment visit of regenerative endodontics procedure. Regenerative endodontics procedure. I'm not going to use EDTA initially. Okay. So the reverse is right. So reverse is right. So option A is wrong. Next one. NaOCl 1% is followed by EDTA 17% is absolutely right. Absolutely right. Okay, so I'll go with option B. Okay, right here it is not 5.2, it should be 1.5%. So it is 1.5% of EDTA, 1.5% of NaOCl, and 17% of EDTA. Any disturbance with my voice? Of NaOCl and 17% of EDTA. Any disturbance with my voice? Hope I'm audible now. I don't know what has happened. Hope I'm audible now. Is it fine? Voice is fine? Hope I'm fine now. So all this softwares and everything. Still echo is coming. Hope I'm fine now. So all this softwares and everything. Still echo is coming. Okay, chalo. So I'll be jumping into the next concept. That is basically silver points. Okay, so one important thing is now normally you see PGs or your seniors are going to do root canal therapy, and whenever I'm doing root canal therapy in the permanent teeth, I'm going to use Gadapacha. So Gadapacha that most of you are aware of. Long back we used to use silver points. Okay, so these silver points are not used nowadays. That we are not using silver points anymore. So long back we use silver points, and the advantage of silver points long back is because you see Gadapacha is very soft. So Gadapacha cannot go into narrow tortuous canals. Even now it is little difficult for us to play with Gadapacha in the narrow tortuous canals. Whereas silver points are stiff. They are stiff, right? So you can easily insert into this narrow tortuous canal. So obturation material of choice in narrow tortuous canals long back is silver points, and of course silver points has many disadvantages. Okay, thing is biocompatibility and all these issues are there because silver, like amalgam, it is going to corrode and it's going to lead to lots of manifestations, and over a period of time you see Gadapacha is giving extraordinary results. So Gadapacha with a good sealer is giving extraordinary seal. So nowadays silver points are gone. We are nowhere using silver points, but you see re-treatment cases, silver points cases are going to come. The patient is going to come with root canal therapy which is done couple of years, couple of decades back, and the patient is going to have some silver points upon radiograph. So you can see silver points like this upon the radiograph. And whenever you are planning to remove these silver points, what is going to happen is silver points can be removed with the help of microsurgery forceps. Okay, or you can use ultrasonics to remove the silver points. Okay, so in ultrasonic file it is work, you peripherally you keep it and it's loosened, by which you are going to hold it with the forceps and you are going to remove this silver points. But one most important thing that you have to make a note about silver points are silver points are regularly contraindicated whenever you are planning for post and core. So post and core, we know how to prepare a post and core, right? Videos are already there. So whenever you have a silver point, and we know silver points, the post and cores are basically prepared with the help of piezo remover. And piezo remover, you cannot insert piezo remover when silver points are there. So post-phase preparations are not done, or you cannot do a post-phase preparation whenever you have a silver points. Okay, right? So that is the most important thing. And this is how whenever the treatment fails, I'm going to remove the silver points. Here you can see the difference between the radio opaque density of a silver point on one side and gutta percha on other side. Okay, so radiographic density. So silver points are more radio opaque compared to that of the gutta percha on a radiograph, and this is how I'm going to remove the silver points. Okay, now if you check out the question, okay, if you check out the question, the crown of an RC treated teeth is fractured near the gingival margin. So it is fractured near the gingival margin. So probably like this at this level, above the CH level, gingival margin, and the coronal end of the silver point is visible at that level. So I got to know the observation material, whatever that is used in this particular teeth is silver points. Okay. Now, whenever a crown that is being fractured at a coronal level, post and core is mandatory because core cannot be held without a post. The main reason why I am using a post is to hold the core. Retention of the core is the primary purpose of the post. So I need to go for a post and core in this particular case, and silver points, I told you, it is contraindicated whenever you are planning a post and core. So now what I'm going to do, I'm going to remove the silver cone, retreat the canal using gutta percha, then prepare my post and core space along with the piezo rimmer. I have the answer is option C. I hope this is very, very clear, right? So main point to be noted in this case-based discussion is post and core preparation. Whenever you are planning for a post and core preparation, silver points are not used as an obturation material. Normally, we are going to use gutta percha as an obturation material. Okay, guys, and I hope you are familiar with this particular instrument, which is again a very frequently asked question for you. A very frequently asked question for you. Right, so this is nothing but called as bar broach. Okay, so bar broach, the major use, the primary use of the bar broach is exportation of pulp. Exportation of pulp. Apart from this is also used in removal of, this is also used in removal of paper points and cotton pellets from the root canal system. Okay, so this is basically used. And you see different cross sections of files. Again, these cross sections are again very frequently asked, which is already covered in your instrumentation smart video along with the notes. Okay, main is that most of us are aware that your okay, so here your H files cross section is a very a frequently asked area for us. H file cross section is a very frequently asked area for us, and H files are basically available as a reverse Christmas tree. They are available as a reverse Christmas tree. And apart from this, the most important thing that you have to make a note regarding the H file is H file has some sort of modifications, and your uni file and S file are going to come as a modifications of H file. You can see the cross sectional similar cross sections, slight modification of H file. And coming to the lines which are given regarding the H file in your Grossman are, okay, H file is basically prepared from round stainless steel wire which is machined into spiral flutes, which is basically machined into spiral flutes. And this instrument has high cutting efficiency. This instrument has high cutting efficiency than K file, but the most important problem of the H file is it easily breaks. Okay, so which file easily breaks? Options: H file, K file, and reamer, which easily breaks. And among guys, is there any issue with my voice? I hope my in my device my voice is audible. Which file easily breaks? Okay, so among the files, the easily file which is going to break very frequently, high incidence of breakage is seen with H file. Among the instruments in endo, the instrument which breaks very frequently is bar broach. So most frequency instrument is bar gouge, file is H file. Okay. So, but H file is going to have more cutting efficiency. The more cutting efficiency of H file is basically due to more positive rake angle. The better cutting efficiency is basically due to positive rake angle. Okay. And the blade has cutting rather than scraping angle. Okay. And how I'm going to use H file? I'm going to use H file in only one direction, retraction, and never in torque motion. Never in torque motion. Whether other files and everything I'm going to use in the torque motion, but H file I'm going to use in only one direction in the case of retraction mode, because the flutes are made in such a way that cutting process can be easily made. I just want to jump into question number 11, which is given here. That is, which is one of the key characteristic feature of H file. H file. Okay. What is the key characteristic feature of H file? H file is designed to be used in torquing motion. No, I'm not going to use it in torquing motion. Less efficient than K file. No, cutting efficiency I was talking about. Cutting efficiency is more for H file, so that is a wrong statement. It has a greater cutting efficiency due to positive rake angle. It's the right statement. It can be used both in retraction as well as torsion motions. No, it is used only in a single motion called as retraction motion. Okay, right? So, guys, I'm little sorry for this echo. Maybe there's some software issue. So that could be the reason. Okay, so I cannot rectify that as of now. But anyway, we are almost done with the 50 minutes class. Okay, so today I'm closing the session. Tomorrow sharp 6:30, we will meet in our regular Zoom class. Okay, in our regular Zoom class, the link will be shared both in the demo groups as well as in the registered groups. And if 2026 students also want to attend, I'll be giving you the access and we'll be discussing the leftover questions in tomorrow's class, considering the audio disturbance. I'm a little sorry for that. Okay, we'll catch up tomorrow, sharp 6:30. Sunday, tomorrow is Sunday, right? So morning I have a community session for 2026 batch, and I will address your session sharp 6:30 on our YouTube, on our Zoom class, which will be posted. The links, free links will be posted both in the registered student group as well as the demo student group. Okay, sorry for the inconvenience. Chalo, I'm done for today. We'll see you again tomorrow. Bye. Take care. Make sure keep the subscription button on, bell notification on, so that you're going to get all updates regarding the examinations as well as the PSCs, updates, all over dentistry and classes.